All right, hello. My name is Karkhanis. I'm a current senior at James Madison University studying health administration, and I wrote my paper on improving the effectiveness of root cause analysis in hospitals. Before I begin, I'd first like to thank RCA ACHE for allowing me to be here. I'd like to thank our program at JMU, and I'd also like to thank our now retired program director, Dr. John Thompson, for helping me not just with the paper, but throughout my entire college career. So my inspiration for this paper, I actually had a summer internship in a 200-bed hospital in their quality and patient safety department. And I started to notice they had a lot of ineffective processes around their RCA process and how they analyzed adverse events. So I reached out to other hospitals in the state, found they had the same issue, and then found it was an issue across hospitals all over. So I interviewed our quality coordinators, and these are the big issues that they said were wrong. So there was a big lack of standardization. They said it was a time-consuming process, a cumbersome process. They had an issue with storage, follow-up. So I thought it was interesting to show this because, yes, this is just one hospital, but a bunch of hospitals have this issue too. So a recent study done by the University of Chicago said that 21% of adults have experienced a medical error. So that's a pretty large amount of people. So the medical field really realized that they need to push for patient safety, which is where the RCA comes in. So the Joint Commission defines the root cause analysis process as a process for identifying the basic or causal factors underlying variation in performance, including the occurrence or possible occurrence of a sentinel event and all of its related tools. Now, the average reported cost to conduct a formal RCA is about $25,000. So if the research is correct and if it really is an ineffective process, then we're really wasting valuable resources. So a little bit of background. The RCA came out of the patient safety quality movement, and I can't mention that without mentioning the Institute of Medicine's report in 1999 to Err is Human. And it was in that report where they said that there were up to 98,000 deaths due to preventable medical errors each year. And so these medical errors cost hospitals between $17 and $29 billion a year. So the IOM really began this push towards patient safety, and they found that these errors were often not due to individual errors or individual mistakes. They were oftentimes due to problems in the system. So that's where the RCA comes out, because the RCA really wants to find those system problems. So the Institute of Healthcare Improvement identifies 6 common steps in the root cause analysis, which are identify what happened, to determine what should have happened, determine causes, develop causal statements, generate a list of recommended actions, and write and share a summary. Now, why the RCA is worth saving? There are over 7,000 root cause analysis submitted to the U.S. Department of Veterans Affairs, 4,100 submitted to the Joint Commission, and several others submitted to state health departments, and these numbers just keep increasing. So they are a very big process in the hospital. So first, I'd like to share a few quotes that I thought were important, because these are individuals who really found an importance in the RCA and focused on it, and they have been using it effectively. So John Woker is an executive vice president of Community Medical Center, which is the first internationally accredited Joint Commission hospital. So he said an RCA or its equivalent is one of the very best tools for understanding the what, how, and why questions that are essential to make recommendations for improvements. And then Robert Wachter is the board of the American Board of Internal Medicine, and he's the chairman. And he said, "I'm quite confident that our RCA transformation has been the most powerful thing we've done to improve safety." So what's currently wrong with the RCA? Through the research, I've identified 3 main problems with the RCA, including the variation in the RCA process, confusion of the systems approach, and inadequate feedback. So within variation of the RCA process, a lot of the reasoning behind that is different tools are being used. So for example, there is the 5 whys technique. There's the Ishikawa diagram or the fishbone diagram. There is the logic tree, and all of these have very different ways of finding the root causes, ultimately leading to some different root causes being found. And then there's also different expectations from accrediting organizations. So for example, the Joint Commission has pages and pages of questions that they require hospitals to turn in, whereas Det Norske Veritas, or DNV, actually has a 2-page form simply summarizing what the event was and what they're doing to fix it. So then there's also confusions of the systems approach, and this happens on the provider side because they are always struggling an internal battle with their duty to the hospital, their duty to their patients, and their duty to themselves. So for example, if they witness something happening or if they're the reason that there was harm to a patient, they may be a little hesitant to say something for fear of possible legal repercussions. And then organizations also have this issue as they have to balance accountability and blame. So whereas they are supposed to focus on the system problems, sometimes there are actual problems with individuals that they need to address. And then inadequate feedback. Oftentimes there is no feedback system, which was concerning because as I found, according to a survey published in the Quality and Safety Healthcare Journal, 57.7% of doctors and 61.8% of nurses stated that a lack of feedback was their greatest barrier to reporting. And then also along with that is weak solutions. These solutions really need to be pertinent to the issue that happened and feasible to execute. And from the research I found that that's not always the case. So I have 3 proposed solutions, including standardizing, culture change, and follow-up procedures. So under standardizing, creating standard forms is a big way to do this. So for the investigation forms, the timeline of events, and the action plans, these should all be the same forms for each process done, as the different teams will all be doing the same process and will all be documenting things in the same place. And then also reevaluating your accrediting organization. So as I said, the Joint Commission is very strict with what they want, whereas DNV gives you a little bit more flexibility. So maybe you like that structure, or maybe you like having a little bit of freedom. So that's important to evaluate. And then culture change. So it sounds like kind of an arduous task, I know, but there's some things you can do that are a little bit easier to help you out. So support from senior leadership is a big one. Simply attending these RCA meetings, maybe disseminating the action plans themselves, or even holding educational sessions around the RCA process. And then also transparency is a really big one. Healthcare organizations can promote their leaders' accountability for safer systems. They can better engage clinicians in improvement efforts and engender greater patient trust through transparency. And then follow-up procedures. There should be an active surveillance of issues, making the organization a much more proactive organization rather than reactive. And then there should be internal audits, which proactively monitor the quality of care and focus on organization-specific risk areas. So in conclusion, after several years of using the RCA as the dominant means of detecting errors, it's really time that we focus on the limitations of this process. The RCA at this point should really be generating a much greater return on investment. And as I said, the barriers hindering the RCA's success is variation in the RCA process, confusion of the systems approach, and inadequate feedback. And then solutions identified, standardization, culture change, implementation of follow-up procedures. So if you follow these solutions, there will be a focus on creating a safe and honest environment for patients that results in a much more efficient use of funds and higher satisfaction rates. Thanks.